हेलो। चेक।
Morning. Good morning, everyone. Dengue virus infection in liver disease. Dengue is the most common viral hemorrhagic fever globally. Recent estimates more than 400 million annual cases with more than 5 billion people at risk. Expansion into the non-endemic regions due to climate shift. This surge is linked to the contributors such as rapid urbanization, climate change, deforestation, poor waste management practices, and increased population density. These facilitate the spreading of primary vector Aedes aegypti. Transition from classic symptoms to multi-organ involvement like liver, heart, and CNS. Hepatic involvement is no longer considered atypical but a core feature of severe disease. Rise in liver function test is prevalent in dengue-associated liver involvement. Patients with liver involvement present with abdominal pain, nausea, vomiting, and anorexia. Hepatomegaly ranges from 4% to 52% of patients. The liver injury in dengue ranges from asymptomatic hepatic transaminase elevation to life-threatening ALF. Dengue is an arbovirus belonging to the family Flaviviridae, genus Flavivirus. It is derived from the Swahili word dinga, which means fastidious or careful, which would describe the gait of a person suffering from the bone pain of dengue fever. It is 40 to 50 nanometer in diameter that harbors an RNA genome of 11 kilobases. Its virion shows an icosahedral envelope arrangement surrounding a spherical nucleocapsid core measuring 30 nanometer in diameter. The genetic material comprises a single open reading frame flanked by untranslated regions at 5' and 3' ends. The ORF translates into a single polyprotein undergoing cleavage at specific locations by either the viral NS2B NS3 protease or a host-derived signalase. This process generates three structural protein, capsid, premembrane, membrane, and envelope, along with the 7 non-structural proteins NS1, NS2A, NS2B, NS3, NS4A, NS4B, and NS5. The virion comprises structural proteins essential for forming its components and non-structural proteins facilitating the replication. Among the non-structural proteins, NS1 has diagnostic importance. Dengue infection is prevalent in tropical and subtropical regions, especially in the Southeast Asia, America, and Pacific Islands. Brazil, Argentina, and Paraguay report the highest numbers. Highest global burden with major outbreaks are reported from Indonesia, India, and Vietnam. The infection is endemic in more than 100 tropical and subtropical countries. However, despite its endemicity to tropical regions, recent trend indicates spread to previously unaffected areas, including parts of Southern Europe and United States of America. In India, dengue situation has become endemic in several states despite differing patterns throughout the past few years. In 2021, there were 193,245 cases with 346 deaths. While in 2022, there was an increase in the number of cases to 233,000, although the number of deaths declined to 303. Furthermore, in 2023, there were 485 fatalities and 289,000 cases. As of 2025, there were 113,000 cases with 95 deaths reported. Transmission of dengue occurs primarily through the bite of infected female Aedes aegypti and to a lesser extent Aedes albopictus mosquitoes. The mosquito bites person infected with the dengue. Mosquito becomes infected with the dengue and undergoes an extrinsic incubation period. Then infected mosquito bites the uninfected humans and new humans are infected with the dengue virus. The Aedes aegypti are daytime feeders. They are mostly active in the early morning and late afternoon. They are highly urban and domestic. Mosquitoes thrive in the human environments, breeding in the small amounts of water found in vases, tires, and gutters. They have an anthropophilic behavior and have an egg-laying habit. The rare modes of transmission are maternal transmission, which can occur during the pregnancy or at the time of birth. Other modes of transmission are blood transfusion, organ transplant, bone marrow transplants, and rare cases have been reported from needle stick injuries or lab accidents involving the infected blood. WHO classifies dengue into dengue without warning signs, dengue with warning signs, and severe dengue. Dengue without warning signs is a probable dengue people living or traveling to the endemic area, fever along with following any of the two criteria like nausea, vomiting, rash, aches and pains, tourniquet test positive, leukopenia, and presence of any warning sign with a lab confirmation of the dengue infection in the form of NS1 or IgM. Dengue with warning signs is presence of warning signs in the form of abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleeding, lethargy, restlessness, postural hypotension, palpable hepatomegaly more than 2 centimeter, and progressive increase in hematocrit. Severe dengue is defined as shock or respiratory distress due to the severe plasma leakage, severe bleeding based on evaluation by the attending physician, and severe organ involvement such as liver or heart. Primary and secondary dengue infections. Primary dengue infection is defined as dengue infection occurring in a patient with no prior immunity to any dengue virus serotype. It usually results in a self-limiting febrile illness or is asymptomatic. Secondary dengue infection is defined as dengue occurring in a patient previously infected by a different serotype, and there is significantly higher risk of severe dengue due to the antibody-dependent enhancement in which the dengue virus produces both neutralizing and non-neutralizing antibodies. The non-neutralizing antibodies last lifelong and are heterotypic in nature. The antibodies produced following the first serotype infection can bind to a second serotype during the secondary dengue infection, but instead of neutralizing the secondary serotype, it protects it from host immune system. Virus antibody immune complexes are internalized via antibody interaction with the Fc receptor, resulting in antibody-dependent enhancement of viral infection and replication. Non-neutralizing antibodies promote recruitment of mononuclear cells followed by release of cytokines, leading to severity of secondary dengue infection. AD is remarkably observed when serotype 1 infection is followed by serotype 2, which also claims to be the most severe form of dengue infection. Mechanisms of liver injury in dengue. The liver injury can occur via direct viral effects. The virus replicates in the hepatocytes and Kupffer cells. Cytokine storm leads to the collateral hepatocyte apoptosis. Hypoperfusion in the form of ischemic injury to the dengue shock syndrome. And metabolic stress, oxidative stress is exacerbated in patients with obesity. Liver involvement in dengue occurs in the form of chronic liver disease patient or a non-liver disease patient. Dengue has also been implicated as the cause of worsening chronic liver disease, that is being the acute component of acute on chronic liver failure. A retrospective study conducted in India in 2015 found that patients with cirrhosis lack classical clinical features of dengue virus infection. Unlike the typical presentation of hemoconcentration seen in these patients may present with low hemoglobin levels and existing low hemoglobin levels and pre-existing thrombocytopenia due to portal hypertension, potentially obscuring the diagnosis of dengue. The study also reported that cirrhotic patients tend to have poor clinical outcomes, including longer hospital stay. The patients with a chronic liver disease, they have more chronic inflammation, reduced synthesis of clotting factors, platelet dysfunction, and low serum albumin, all of which contributes to the exacerbated cytokine storm, severe capillary leakage, increased hemorrhagic risk due to the reduced secretion of clotting factors, aggravated hepatic damage, and higher incidence of severe dengue or dengue hemorrhagic fever. Comparison of liver enzymes in classical viral hepatitis versus dengue. It is well established that dengue virus infection leads to elevated transaminases, which are typically observed after day 3 of illness. A characteristic biochemical feature is an increase in the AST-ALT ratio, with AST levels generally exceeding the ALT levels. This is due to the mitochondrial injury and additional release of AST from the skeletal muscle during dengue virus infection associated myositis. This pattern contrasts with the viral hepatitis A, B, C, where the ALT predominates. Extremely high AST or ALT values, more than 1,000 international units, are suggestive of dengue-associated severe hepatitis and are associated with a high risk of progression to ALF. The coagulation profile in dengue. The liver is the main factory for clotting factors. In chronic liver disease, there is already severe hypoprothrombinemia and low levels of protein C, S, and antithrombin. This leads to the incomplete baseline clots. Dengue causes bone marrow suppression and immune-mediated destruction of platelets. The combination of low baseline factors in CLD and acute consumption of platelets in dengue leads to the disseminated intravascular coagulation and catastrophic bleeding. This is a study conducted at ILBS by Kulkarni V in 2015. Males accounted for 61% of the study population and mean age was significantly higher in group C. In this study, the patients were divided into 3 groups: Group A with no underlying liver disease, Group B with chronic hepatitis, and Group C with cirrhosis. The clinical features observed were classical dengue fever in 89 patients, dengue hemorrhagic fever in 2 patients, acute liver failure in 1 patient, and ACLF in 3 patients. Fever was universally present in all the patients. Jaundice was present in 58% of the patients, only in the Group C, and 8.3% patients in the Group A and Group B. Similarly, there were greater number of Group C patients with ascites as compared to the Group A and Group B. Underlying cirrhosis with 1 ethanol-related cirrhosis and dengue type 2, serotype 2 was isolated in the samples. The median levels of AST and ALT were significantly low in Group C. Patients with Group C had low albumin as compared to the Group A and Group B. Cirrhotics had significantly prolonged INR as compared to the Group A and Group B. And mortality was seen in 3 in Group C, 1 in Group A, and none in Group B. The INR and bilirubin were the predictor of liver failure. Dengue infection ranges from simple fever to acute and chronic liver failure and acute liver failure. Cirrhotic patients lack classical features of dengue and have poorer prognosis. This was another study conducted by Jayachandra et al., which showed that EPRI as a predictor of severe dengue. And in this study, there was a significant association between the EPRI value and hospital stay with a p-value of less than 0.005. A total of 33 patients required platelet transfusion, among which 27 patients had an EPRI score of more than 3.2. This was significant with a p-value of 0.00. Similarly, in a study conducted in China by Zhang et al. Showed that patients are at high risk of developing severe dengue. So these studies show that EPRI was identified as a valuable predictor of patients with severe dengue. Combining the WBC, platelet count, and EPRI scores allowed a better prediction, but overall EPRI was a predictor of severe dengue in both the studies. This is a hospital-based study with a large number of patients of dengue infection. Incidence of dengue hepatitis was 11.9%. Patient with dengue hepatitis had high inpatient mortality with a multi-organ failure as a main cause of death. Median age of presentation was 29. 67% of the population was male, in which 50% had severe dengue, 30% had severe dengue hepatitis, and 16% had dengue shock syndrome, along with 4% had an incidence of acute liver failure. Mortality was 17%, with cause of death identified as multi-organ failure and septic shock. The presence of shock independently predicted the mortality with an odds ratio of 6.4. 60 to 90% of the dengue infected patients present with hepatic complications. Dengue virus is known to infect the hepatocytes and Kupffer cells. Mechanism of liver injury in dengue may be due to the direct effect of the virus or host immune response on the liver cells. Circulatory compromise, metabolic acidosis, or hypoxia caused by hypotension or localized vascular leakage inside the liver. Drug toxicity also contributes to the liver damage. Dengue ALF is more common in children as compared to the adults and is associated with a higher mortality rate. Even though most of the patients might improve with supportive care, liver transplantation may be a therapeutic option in refractory cases. Over the years, ALF survival rates have significantly improved due to advances in the disease understanding, intensive care, and timely liver transplantation. Although challenging due to the increased risk of bleeding and hemodynamic instability, cases of successful liver transplant in patients with dengue-induced liver failure, including both cadaveric and live donor liver transplants, have been reported. This was a study conducted by Devi Bharvi et al. Showed that dengue hepatitis progressed to ALF in 0.35% of the patients. Development of ALF was associated with a high mortality and lactate level, pH, and MELD score at the admission were significant determinants of the outcome. Other studies conducted at India showed incidence of ALF ranging from 0.35% to 4%. Study conducted at Sri Lanka and Thailand showed prevalence of dengue ALF of 6.6 and 0.71% respectively. Dengue-related ALF, Gallant et al. Described 42-year-old Jamaican woman who had presented with markedly elevated transaminases, coagulopathy, thrombocytopenia, metabolic acidosis, jaundice, and hepatic encephalopathy. She underwent urgent cadaveric liver transplantation within 24 hours of admission and subsequently made a full recovery. Bhargav et al. Reported the first LDLT performed for dengue ALF in a 29-year-old woman with serologically confirmed dengue-related ALF and shock, who was treated successfully with an emergency LDLT. In post-liver transplant patient, case series from India describes the management of 4 contrasting dengue ALF, 2 of which were managed conservatively, while the other 2 underwent liver transplant for dengue-related ALF. And another study conducted at New Delhi showed 3 cases of post-liver transplant dengue infection, in which fever and thrombocytopenia were the primary features. All the 3 patients recovered well with the supportive care. Donor-derived dengue infection was reported in 2 cases. A case of transmission of dengue virus from donor to recipient after liver transplantation. The recipient had history of multiple admissions for hepatic encephalopathy and ascites. He was admitted in the ICU for 15 days for chronic liver disease, ascites, and acute kidney injury before the transplantation. The donor was admitted 1 day before transplantation. The donor spiked fever on post-operative day 2, followed by thrombocytopenia and elevated liver enzymes. The donor blood test was positive for dengue NS1 antigen. The recipient also had similar clinical picture on post-operative day 5, and his blood test was also positive for NS1 antigen. Hence, the diagnosis for post-transplant donor-derived allograft-related transmission of dengue infection was made. Both recipient and donor were treated with supportive measures and discharged after their full recovery on post-operative day 9 and 18 respectively. Another case was a 38-year-old male who underwent LDLT for hepatitis B-related cirrhosis. The donor was his 19-year-old son. The immediate post-operative period was uncomplicated. On post-operative day 6, the recipient developed the fever, thrombocytopenia, and severe graft dysfunction. His blood tests were positive for dengue NS1 antigen. His donor, who also had the fever after the operation without significant derangement of liver enzymes or thrombocytopenia, was also found to be positive for this as well. On further evaluation, both the recipient and the donor were found to be positive for the same serotype of dengue virus RNA by RT-PCR. A diagnosis of post-transplant dengue infection was made, and there was a strong suspicion of transmission of dengue infection from donor to the recipient. The recipient was treated with supportive measures, including adequate hydration, correction of coagulopathy, broad-spectrum antibiotics, and optimization of immunosuppressive dose. The recipient improved over the next 2 weeks. Moving on to the lab diagnosis of dengue infection, NS1 antigen becomes detectable from day 1 of fever and remains positive up to 18 days. It is highly specific as it differentiates between the different flaviviruses. IgM appears first after 5 days of fever and disappears within 90 days. IgG is detectable at low titer in 14 to 21 days of illness, and then it slowly increases. In secondary infection, IgG antibody titers rise rapidly. IgG is often cross-reactive with many flaviviruses, which gives positive results in a case of infection with yellow fever virus or Japanese encephalitis. Dengue virus can be detected in blood from 1 to 5 days after onset of symptoms, and virus isolation can be done by inoculation into the mosquito cell line. Primary dengue infection, in which the viral RNA and NS1 antigen peak within the first 2 to 5 days of symptoms, and IgM appears around day 3 to day 5. IgG appears late around day 7. Secondary dengue infection, in which the viral RNA and NS1 antigen are present, but IgG levels are already high and rise almost immediately. We can differentiate between the primary and secondary dengue infection by the IgM-IgG ratio of more than 1.2 indicates primary dengue, and an obsolete test, which a HAI titer primary dengue is less than 1:1280 significant tells about the primary dengue. The present study demonstrates a significant association between dengue viremia levels and disease severity. A total of 72 patients were found to be suffering from primary dengue and 54 from secondary dengue. The study was conducted on the hospitalized adults along with the acute febrile illness and presented within 3 days of onset of fever. The most common serotype detected was serotype 1 in 37 cases, followed by serotype 2 in 34 cases, and 10 in serotype 3 in 10 patients, and serotype 4 in 3 patients. As per the WHO revised criteria, 93 cases were dengue without warning signs, 20 were with warning signs, and 13 were severe dengue. The quantification of the viremia was done. The viremia levels of all the patients were plotted according to the illness days, and it was observed that highest median viremia was seen on day 2, followed by day 3. Viremia levels were seen to decrease as the dengue infection progressed. Day-wise viremia level were observed to be higher in primary dengue as compared to the secondary dengue. In secondary dengue, median day 3 viremia was significantly higher in dengue hemorrhagic fever or severe dengue, and peak viremia was also observed to be significantly higher in cases in the secondary dengue. Daily mean viremia levels were higher in severe dengue as compared to the dengue without warning signs and dengue with warning signs. Day 3 viremia levels were statistically significant. Out of 54 secondary dengue cases, 14 were severe dengue as compared to just 1 in primary dengue. Severe disease tend to occur in secondary dengue infections due to antibody-dependent enhancement. Cutoff value was defined as, and day 3 dengue viremia can be used to predict the severe dengue disease. Contrasting to this, a study was conducted by Agrawal et al. At 3 tertiary care centers in India, where 619 children with confirmed dengue infection were studied between 2012 and 18. The characteristics of these patients are shown in table 1. The age of the children ranged from 2 months to 16 years, and all site includes both males and females. The infecting dengue virus serotype was identified and seen as dengue 1 with 45%, dengue 2 as 34%, 3 as 13%, and 4 as 1.9%. Patients with confirmed dengue infection were classified as primary or secondary dengue based on the ratio of index. Analysis of primary versus secondary infection in all the 3 sites showed mixture of primary and secondary infections. Disease severity in these patients was done using the WHO guidelines. Of the 619 children, 32% has severe dengue, 58 exhibited dengue infection with warning signs, and 8.7% had dengue infection without warning sign. Of importance was the finding that the frequency of severe disease cases was essentially similar in patients with primary versus secondary, that is 32%. This data showed that disease severity was not preferentially associated with the secondary infections in this study. This trend of severe dengue during primary infection was not unique to a single site, but at all the 3 clinical sites included in the study.
No, what happened? You have
Severe
just
dengue was associated between the
just have
primary
3 minutes more.
primary and secondary dengue, but was not associated with particular dengue serotype. There were fatalities associated. Severe dengue is not confined to the secondary infection, and therefore dengue vaccines must be considered in both primary and secondary infections. Dengue serotyping is needed for epidemiological surveillance, understanding the disease severity, vaccine and therapeutic research, and outbreak control. These are the studies showing the changing in epidemiology of dengue in Delhi, in which all the 4 dengue serotypes are co-circulating in the year 2003 to 2005. After that, there was dengue serotype 1 in Delhi during the 2010 and 11, and there was dengue 3 exhibiting the highest substitution rate and most recent evolutionary among all the 3 serotypes. There was circulation of dengue 3, genotype 3 during the 17 to 18 in Delhi. Management includes the patients are categorized into Group A, Group B, and Group C. Group A are the stable patients recommended with the home management. Group B with the warning signs with hospital management, and severe dengue requiring the emergency management. Coming on to the prevention of dengue, which includes the environmental prevention, chemical prevention, personal prophylactic measures, and the biological preventive measures. 2 dengue vaccines are currently recognized on the global stage, Dengvaxia and Qdenga. Dengvaxia was developed by the Sanofi Pasteur. It is a live attenuated vaccine. 3 doses are recommended, but it is recommended only in seropositive individuals. This is a critical issue as WHO recommends only in seropositive individuals. And if given to someone who has never been infected, there is a serious risk of antibody-dependent enhancement. Next is Qdenga, which has the 2-dose schedule, and WHO has updated its guidelines to allow its use in endemic areas regardless of the prior infection. Transition now to the future of dengue prevention in India, focusing on indigenous vaccine candidates. First is Dengue All, a collaboration with the ICMR. This is a live attenuated vaccine. It has completed its phase 3 trials, and target launch is anticipated in the 2027. And the second one is Dengue Sil. It is to be given in the children aged 2 to 18 years, and target launch is anticipated around 2029. Moving on to the data of ILBS, total request received for dengue fever was 5,412, among which 376 cases, that is around 7%, were serologically confirmed dengue. 38.2% were NS1 positive, 55.2% was IgM positive, and 6.5% were both IgM and NS1 positive. WHO classified clinical severity, 80% of them presented with dengue fever, 12% presented with dengue fever with warning signs, and 8.5% presented with severe dengue. 5% incidence of dengue-related ALF was noted, among which 61% patients survived and mortality of 39%. The baseline characteristics of the study population was median age was 32 years, along with...
Please Lakshi, conclude. Please conclude.
So, There was predominant of dengue serotype 2 followed by 3 and 1, and predominant genotype was cosmopolitan. Dengue virus remains a formidable and expanding global health threat. Majority of infections are self-limiting but progress to severe disease. Survival rates have significantly improved due to advances in the disease understanding, intensive care, and timely availability of liver transplantation. Dengue virus serotyping and genotyping helps understand the epidemiology, evolution, and transmission of the virus required for effective disease surveillance and controlled efforts.
I think excellent coverage, is a vast topic, and
I thank Dr. Ekta ma'am for her constant and valuable inputs, and I thank Dr. Ishu Agarwal and Dr. Arzu for providing me with the data to be shown here. Thank you.
thank you. I think we don't have much time for if there is one quick comment or question. Otherwise, we'll move to the next presentation. Dr. Ekta wants to say something.
Good morning. So why we wanted to take this is that often dengue in India or in Delhi, because it's endemic disease, is not considered, people think that it's just a fever. But when there is an underlying comorbidities, and especially like in liver disease, this can be severe dengue and can be associated with life-threatening condition like ALF. So it's we are seeing, especially in the pediatric population. So that is why we wanted awareness about this. And very soon in India, I think the indigenous vaccine is going to come. One vaccine which is available is not suitable for Indian population, because here all the serotypes co-circulate. So we have to be very, very careful, especially the clinicians, to evaluate whether you are dealing with a primary dengue infection or secondary, so that taking the history of previous exposures or any other documented dengue infection is very, very important. So
She
I
did
think
mention.
she mentioned those AST.
No, she did mention. She did show one slide.
Okay. I think your clinical presentation was yes.
Yeah.
And we do not see classical sign and symptoms, especially in cirrhotics. This is what the literature is coming up. So lab diagnosis, if you suspect there is a fever, is must. And another thing which is she did not mention is that secondary dengue infection, NS1 has a limited role. So even if we say that first 9 days NS1 antigen, but now the studies are showing that, so order both NS1 as well as IgM together if you don't, you want to make a quick diagnosis.
Thank you.
Good morning, all. I'm going to present the topic how to create AI models in liver disease. So with a quick brief history of AI, I would like to start. AI is not a new area. It came in 1950 with the Turing test, where machine AI was assessed with a human participant for conversation kind of assessment to recognize whether a machine can compete with a human in terms of intelligence, and it passed. So it started in 1950, and then the AI, artificial intelligence term, was coined by John McCarthy. He is called the father of AI in 1956 in Dortmund Conference. Then
successively different milestones came, like Google Deep Blue beating Gary Kasparov, the chess champion, and then deep learning came in 2012, and ChatGPT, different versions, and now the multimodal analysis generative model agentic AI in 2025. So it's a 75 years of history, long innovations and different landmarks. So with this knowledge, why we will go for AI analysis in healthcare research from our known traditional stats? We should understand little bit. Traditional stats is model driven and descriptive. It's mostly fits to a moderate to small sample data set with homogeneous type of nature, and it's simple to interpret. Mostly it fits a linear model with the assumption of linearity, and it helps to understand a limited area of data, while the machine learning, the AI analysis have the capability to handle the different diverse modality of data, like tabular to image to genomic. Any kind of data can be put together to have a very complex type of analytic inference to get from the data, and it can model different type of clinical application like prediction, risk stratification, and classification type of problems. So it's complex to interpret as well. So if we see the structure of overlapping, the stats and machine learning have some amount of overlap. So machine learning is also high level of statistics that is encapsulated within algorithms. So we call machine learning algorithms, not a simple statistical methods. So it is encapsulated in a package. So after coming this type of capability, AI has lot of application in healthcare, like decision making, improve treatment planning, risk stratification, resource allocation, improved associated care, health through health monitoring through wearable devices, and end of life care. Different domains are there for AI applications. And if we see for from the last few years, if we predict how the market is going to be in next 10 years, it is exponentially increasing the compound annual growth rate, and it will be 25.6 billion market in future. So what is the research plan when we put into the AI in our research, clinical research? Thank you. So the pipeline of the work is establishing a clinical question. That is the most important. So establishing a clinical question, that is the first step, most important part of the research, because a relevant question need to be formulated, whether we use AI or not, because there are already established method to solve a clinical question. AI is not like everything is needed AI. Then the suitable computer vision task or some kind of mechanism to label our data. Mostly it is called supervised learning in AI. Supervised learning is giving data with the outcome, with the level of the data, if it is positive or negative. So that will be used for training a AI algorithm, whether it will see the data and identify the pattern in it, and then using the pattern, it can use new data to give the inference. So that is the main working nature of the AI models. So data collection and good quality data and its pre-processing to make it usable for the AI model is the very important step, the next steps. And then we need to understand what are the softwares available to solve our problem and the required hardware level, and then model the parameters, the hyperparameters, the structure of the model need to be then tuned for our application. And then the validation step comes when the model is ready, that need to be tested on a new data set that is called validating the model. So these are the brief steps of AI-based research plan. So first is the formulation of a clinical question. So how we will identify a problem? What are the suitability of a clinical problem? So most of the time when a clinical task is repetitive, complex and time consuming, then we will go for AI. And then the decision that evolves from various radiology or pathological fields or other type of different signal data are involved for a decision making, for differential diagnostic, where multiple things are involved. Then also this AI can play a very crucial role to formulate a multi-modal data and give a inference or some probabilistic result to make decision more objective. So, and for this, of course, a close collaboration between engineers and scientists are needed. So for the AI model, what will be our sample size? So far, we used our sample size based on our hypothesis and type 1, type 2 error. But here, it is not the case. We are now modeling the data itself. We are giving something for exact inference and maybe at a personalized level. So for AI-based model, we need a predictive performance and the accuracy. We have to optimize the accuracy for the prediction. So now the sample size will be based on the prediction parameters, the number of event and the expected AUROC level and the target 95 confidence interval. So the how many parameters we are using for AI model development and what are the amount of accuracy we need with 95% confidence interval, that is the main point. So how many parameters and what are the different modalities we are using and what are the number of class we are going to predict, that is the key factor for our sample size calculation. So there are different papers already have quoted what are the suitable number. So some paper have shown beyond 1,000 sample size for a machine learning model, not deep learning. I'm not talking about deep learning. For simple machine learning model, beyond 1,000 data set, it does not improve much. So we can take a rule of thumb like 1,000 data set will be good for a start. So next comes what are the different type of data sets. So from imaging to structural clinical data, lifestyle data, speech, surgical omics, unstructured medical reports, that is the discharge report maybe, histology, different modalities are there and that can be put together really. And of course, longitudinal data is also there. So the delta parameters can be also incorporated into the model. How the parameters are changing, how the patient treatment response are changing. So based on all these things, a model can be developed. So for data collection, some points need to be taken care. So data have two primary forms, structured and unstructured. Structure is the all type of tabular data, lab results, demographic, etc. Unstructured is the clinical note, discharge report, medical images, voice recording, maybe video. So all these are unstructured data. So there are specific standards to pre-process this type of data. Structured data is already well known, and how we use for standard statistical method, already the traditional statistical method, this is the same. But for unstructured data, there is certain standards that need to be followed. So this type of details is not possible to cover in this short type. So there is one course work going on in every Saturday 4 to 5. So when it is possible for you to manage the time, please attend the classes if you are interested. So there are a lot of challenge, of course, for data collection, like ethical clearance, the data privacy security, because a lot of data, maybe voice, maybe facial image, also maybe included in the model. So there are a lot of data security and privacy concern are there. And it is a costly, time-consuming process, and mostly the labeling the data, whether it is belong to a positive class or negative class, that needs a long time and expertise, clinicians valuable time. So it's the bottleneck for AI research. So there are other mechanism for it also, like crowdsourcing, web scraping, and gathering data from the open source sources, and data augmentation is also another process that comes under data pre-processing. So the pre-processing steps, data cleaning, normalization, annotation, these are I have already discussed. Data augmentation is the process when we have limited data and we cannot have much time or cost to invest in it. We can generate new data from the existing data set using some deep learning model. So there is data augmentation models available. That is a very good news, that can generate new data set depending upon the old. And next is the splitting of the data for training and validation, that I have already explained what is training and what is validation. So mostly it is 70-30 random splitting of the data. And the manual annotation is a bottleneck that I have already mentioned. And there are automated data annotation tools available. While it saves a lot of time for the annotation, the marking of the region of interest, mainly in the image data, and other type of marking, labeling is possible. So now come to the choice of AI models. So the diagram is showing a broad overview of what are the available things are there. So in under machine learning, two different sectors are there, supervised and unsupervised. And in unsupervised, we do not give the class labels with the data. So model inherently see what are the inherent pattern in the model, and it clusterized the things for different type of characteristics. These details can be covered in class only. There are deep learning models also for computer vision tasks, imaging and video data, and natural language processing like large language model and other type of text data handling. So these are very broad overview, and there are a lot of different model, and for different application they are suitable. So this domain knowledge is very much needed to identify what model will work for us. And after the model development, the performance evaluation and interpretation is important for clinician to understand how the model is working, and what is the explainability of the model is also very important for gaining trust. So comparison is also needed, and the clinical utility assessment is also very important. So I'll quickly go because time is not very enough now. So most problematic part in clinical data is it is biased. Most of the time the positive cases are less compared to the healthy cases. So in that case, when we are doing some predictive analysis, if blue level is our healthy cases and green is the pathological case, so it is always the number is very less. So when we calculate accuracy, it is the correct prediction upon total prediction. So always it will be, for this case, always it will be 90%, because 10% is the green level, the pathology, and 90% is the healthy one. So always it will be 90%. But if it is correctly predicting the green levels or not, it will be very problematic to say. So the precision and F1 score and recall is a parameter that tells about how much true positive we are getting from the total predicted positive cases. And recall is the ratio of true positive with the actual true positive, means with the false negative also. And F1 score is the ratio of these two. And with these parameters, the bias data can be assessed for the classification or prediction kind of problem. And there comes another two things: the calibration plot. It gives the X direction the predicted probability, in Y direction it gives the observed event rate. So if the plots are along the 45-degree angle, then we can say by looking visually, the model is predicting nicely. There are quantitative parameters also for this. It is very useful parameter for AI models. And then the clinical utility of the model, it is very important to identify whether a model is giving clinical benefit with respect to the traditionally used method. So it's again XY plot where Y direction is giving the net benefit across the different threshold probability. Threshold probability tells about what are the probability of taking the method by a patient or clinician, the traditional method. And for the different probability, threshold probability, the clinical benefit is plotted against the traditional model and the AI-based model. So if the model is giving more positive clinical benefit than the traditional method, then it is proved to be a useful method. So it is very, very important parameter for a AI model. And then come the explainability, very important thing for clinical use. It improves trust and reliability, and the improve our clinical decision making and the accountability also for a clinician. So there are different mechanisms like SHAP-based method, parameter importance plot, and for deep learning imaging data, there are heat map, Lime, Deep Leap. These are different software-based mechanism to make the data understandable for clinical decision, how the model is interpreting the data for the clinical decision. What are the reason the model is saying this is positive or this is negative, or where the risk is lying, what parameters are giving the inference for identifying a risk. So that type of understanding it will provide to make a responsible clinical decision and with accountability. Now, there are different challenges, of course. So when the A figure and B figure is comparison of two scenarios. In the A scenario, when we are doing our research, sitting in our institute with our own data, and we are not looking to others, what they are doing, that will be a very segregated, limited type of work, and it will not be a generalized, more without biased model, and it will not be suitable for a clinical decision making type of important task. But when in the B part, when we see there are collaboration within the institutes and different type of data is used for the development phase, and then the validation is done with lot of different variable data sets across the geographic and race, then it will be more generalized and it will be more useful for clinical decision making, of course. And repeated timely, it should be monitored also, how it is giving the results. So most of the time when we do our research, we do data collection, pre-processing, model development, and prediction, and we publish our data. But the next level of things like multicentric validation and explaining the model, and then risk stratification, and then comparison, compliance with medical device regulation, and finally make the solution in our clinical practice. This step, that this right side portion is the most slightly difficult part, and we mostly do not attend this part due to different type of reason, like less amount of funding or less amount of time, because we are always busy in our regular clinical routines. So this need to be taken care. There are some ethical principles associated with it. So informed consent from the patient need to be done and explain the use of their data in research and how their contribution, how it is valuable. Then the fairness, equity, ethical collaboration between different partners, the impact of clinical judgment, the transparency and explainability of the model to make the clinician understand and make the patient, the stakeholder, all the stakeholders should understand what are the pitfalls and advantage of this new technology. So when our model is developed or research level are developing, we should understand what are the technology ready level, the TRL level of our process. So we can apply for patent, when to do the publication, when to go for abstract presentation, that need to be very carefully done. So when we start, it is TRL 0, the first initiation of the concept, then TRL 1, the research around the goal, TRL 2 is the proof of principle, and then 3 is system development, and TRL 4 of the first outcome of the result, the proof of concept. So during this TRL 2 to 4, we need to have filed the patent. After this, when it is in TRL 5, 6, 7, these are all application development, validation phase, and then the deployment stage. So it is quite advanced stage. So when we will do our patent filing at the TRL 2 or 3 level, at least, at most, we should file by TRL level 4, when we have the initial result in our hand, the proof of concept. We should remember this. And when we have published the paper or presented, it is already late for a patent filing. So there are very vast landscape of AI research in liver disease, from the MASL to fibrosis, cirrhosis, hepatocellular carcinogenesis, and then the transplant. So there are a lot of different sectors. I'm not the expert to dig into it. So in this area, if we see for last few decades, there are exponential increase in research. While India have 9th place with a limited number of research in contribution, China, US is very leading position. And if we see the interaction between countries, lot of interaction is going on, but India have very limited exposure in this area. So we should increase our research in AI-based different clinical applications. So if we see what are the different sectors that we can start thinking of, the prognosis and risk assessment, clinical outcome prediction, diagnostic model development, and biomarkers based on different type of modality, like genomics, the lab-based data, or maybe it is radiological data. So these are broad areas. And for deep learning models, the diagnostic, drug discovery, response to treatment, and prognosis and risk assessment models are also there. And there are certain areas that have not touched yet. I will come to that. So here I would like to show you how the explainability works. When we have multiple parameters, here in the C part in the image, there are plots for different parameters, how they are important. So it is a quantitative measure of a parameter, how they are contributing for the decision making. So it tells very clearly the priority list of the parameters. So in this way, the clinical explanation can be derived from the model interpretation. So if we take imaging data, here in the D section of the image, there is pathological slide image, and the heat map is telling which part is high score and low score associated with. So for our decision making, which part is contributing for the decision making, that can be highlighted. What model has learned, that can be visually represented by these methods. So there are very good methods for explainability also, so that clinically that can be very much understood, so that the decision can be taken nicely with accountability. So the research gap, I was talking about some areas. The LLM model for healthcare, especially in liver, has been explored very limitedly so far. So LLM can extract relevant information from large unstructured data like text only. So the discharge report, summarizing the discharge report and summarizing the total different type of report for a patient, for diagnostic or for stratifying the patient for different sectors before going to some treatment, that can be done. That can be very useful for hospital administration also. It can be very useful when a patient come at OPD. So LLM model based research, and another one is deep learning model based research using image or video data for different like diagnostic, risk prediction, or identification of treatment failure, like liver transplant failure or other type of operation, surgical failure, that can be assessed using imaging data also. So these are some application area I have already summarized. And the challenges are, the hallucination is a term that majorly have seen in deep learning models. It gives the result, but most of the time it don't explain why it is giving. The area is limited. So sometimes hallucination is a problem. So always the clinical insight, clinician's insight is very much required for the development phase, and regular interaction of the data science, the technological person and the clinical person is very, very important for development of a model, because the accountability is at the end of the day is clinicians. So to summarize the whole thing, the key takeaways is AI is there to improve current practice. We need to understand when and what to apply. Data quality and pre-processing are the most important, as well as the model itself. Model equation must align with the clinical goal and real-world applicability. We should identify a really relevant clinical question for AI application. Adequate sample size ensures stability and generalizability. Explainability ensures interpretability and trust. And AI development process is iterative. It requires collaboration between clinicians and data scientists. The right side image is showing the workflow of AI research in any healthcare problem that can be applicable to liver research also. The data source, data preparation, then data processing, pre-processing, then model evaluation, development and evaluation, and the adoption of the model with the different regularity and the multicentric validation, and it can be incorporated in daily clinical routine. So thank you for your patience.
Thank you, Isha. It was good. We are all in nursery as of now, and we will take a lot of time. And Isha is an asset. Slowly and slowly, I recommend every DM, MCH, PDCC must have AI included into their thesis, so that we, both the moderators, mentors, guides, and students, we all learn. Thank you, Isha, and we'll all join your classes.
Thank you,
Okay.
sir. All of you are most welcome. I'll be very happy if we see many faces in my class. Thank you.